Hello, and welcome to Social and Behavioral Aspects of Public Health's Determinant of Health project. Our topic is asthma among children in the United States. My name is Daniela Pierre, and my fellow group members are Kelly Murray, Aaron Markle, Hunmi Victor, and Michelle Flavin. Let's get started. The topics that we will discuss today will be the epidemiologic overview of asthma among children, individual levels of determinants at higher levels of social ecological model, and lastly, we'll have our references. Asthma, as defined by the National Institute of Health, NIH, is a chronic lung disease that inflames and narrows the airways. Inflammation of the airways are caused by triggers. Asthmatic triggers include indoor and outdoor allergens. Indoor allergens can be dust mites that are found in carpets, furniture. It could also be animal dander, while outdoor allergens are more of pollen and mold. Infections, exercise, drastic changes in weather, and other airway irritants, such as tobacco smoke or air pollutants, are all asthmatic triggers. Individuals with asthma experience episodes of wheezing, shortness of breath, tightness in their chest, coughing. This all makes it very difficult to breathe. So, the etiology of asthma. It's both an environmental factors and genetic factors combined. There is no confirmed research that proves one is greater than the other, but it's more that it's a combination of both. As the world changes and more buildings are being put up, our environment and the air that we breathe become very different than it was 20 years ago. So we have to take into consideration that environmental factors play a large role in the triggers that are being introduced into the world each and every day. Asthma is one of the most chronic diseases affecting children and the most non-communicable disease. An estimated 6.3 million children under the age of 18 have asthma within the United States. But it's not just the United States that has the issue. This is a global issue affecting millions. The burden of this disease. Children aren't able to go to school with these issues, having an asthmatic episode. The World Health Organization states that most children miss up to about 4 days of school per year or per semester due to asthmatic related issues. Also, the financial obligation. Asthma does not have a cure, it just needs to be managed, and management is via inhaled corticosteroids or a fast acting inhaler. Also, think about the decreased quality of life, especially in children. They're not able to run around in different areas, go to their friend's house because they might have a lot of triggers in that household. So, things that people take for granted on a day-to-day basis, a child with asthma can't. And also mortality. According to the latest World Health Organization estimates released in December 2016, there were an estimated 383,000 deaths due to asthma in the year 2015. So there is an issue of being able to manage asthma and the things that could come with it. Also, healthcare costs and utilizations. Asthma costs in the United States grew from about $53 billion in 2002 to about $56 billion in 2007, about a 6% increase. The World Health Organization also states that the U.S. spends about $3,300 per person that has asthma. If we're spending the money to help manage, we should also help put funds into the environment and reducing the triggers that we have in our community. Next up, I'll talk about the prevalence in the United States and how it's affecting not only children, but children in different races. In this slide, we'll be talking about prevalence. Prevalence, as we know, is the measurement of all individuals affected by a certain disease at a particular time. The disease in this case, of course, is asthma, and the time is 2015. Both of these charts come directly from the Centers of Disease Control and Prevention. We'll start off with the chart that's on the left, which is called Current Asthma Prevalence Percents by Age, Sex, Race, Ethnicity, in the United States in 2015. Now, I would like to note that both these charts are similar. One just shows the numbers, the current numbers within the thousands, while the other just shows the percent and broken into three categories, while the chart on the right just is broken up between the age category. So you can see from both charts that children have a higher prevalence rate. Now, as we go to male and female, females actually have a higher prevalence rate. Now, this can be because females have a longer lifespan or because there's a higher infant mortality rate in males. So the numbers are not exactly the same. Lastly, we see race and ethnicity. African Americans have a higher prevalence rate compared to whites and Hispanics. Now, this can be either genetic factors or environmental factors, but based on research, individuals are saying that it seems like this can be it can be an environmental factor because of housing conditions and other things that they can't control. Now we'll pass it off to Erin, who will talk about individual levels of determinants.
Hi, my name is Erin Markle, and I will be discussing the individual level of determinants for asthma among children. I'd like to first point out that not all asthma is the same. Asthma can be different for different children and can have very different symptoms at different times. Because of this, treatment should be given on an individual level. The assessment and monitoring process utilized by doctors should encompass multiple measures to determine a child's current condition and future risk for worsening of this condition. There are two types of asthma. There's intermittent asthma and persistent asthma. Intermittent asthma is the mildest form of asthma a child can have. It affects them twice a week or less and can be treated with a type of rescue inhaler that will ease the asthma symptoms the child is experiencing at that given moment. Persistent asthma affects the child in a more persistent way. It can be categorized as mild, moderate, or severe. A specific treatment plan needs to be implemented and tailored to the level of severity the child is experiencing at that time. It is also important to note that the type of asthma a child possesses is not static. Even patients who show few daily effects of asthma may be in danger of sudden worsening of these symptoms. Additionally, if the child's condition is left untreated, it may cause worsening of the child's asthma. On the other hand, specific factors can contribute to helping reduce the effects of a child's asthma. Treating coexisting chronic conditions and reducing environmental factors can improve asthma control. Further explanation will be given on the upcoming slides. When it comes to the cause of asthma, doctors do not fully understand the cause among children and adults. They believe that asthma is more likely caused by a combination of genetic and environmental triggers. Listed on this slide and the next couple of following slides are some causes that have been commonly associated with the onset of childhood asthma. The first is genetics. Asthma tends to run in families. Children whose parents have asthma are more likely to develop asthma themselves comparatively to families with parents who do not have asthma. The second cause is an allergic response or allergens in a child's day-to-day life. About 70 to 85% of children with asthma also have allergies. Asthma and allergies often coexist. The allergic response plays a strong role in childhood asthma. In children with allergies, the immune system overreacts to the exposure of the allergens. Asthma is triggered by inhaling certain substances or allergens in the air. Examples of these allergens are dust mites, animal dander, molds, cockroach dust, and plant pollen. Dust mites, specifically their feces, is coated with an enzyme containing powerful allergens that can trigger the allergic response. When discussing animal dander, cats harbor significant allergies and allergens that can trigger the allergic response. Dogs cause fewer problems than cats. The next cause is environmental factors or irritants. Environmental irritants induce or aggravate a child with asthma by direct exposure of irritants to the lungs. Studies indicate that the more indoor allergens to which a child is allergic, the higher the child's risk for severe asthma. Examples of environmental irritants include parental tobacco smoke before and after birth, food allergies, indoor chemicals, and pollution. Parental tobacco smoke has been shown to increase airway responsiveness as early as the first 0 to 10 weeks of life and extends to mothers smoking while pregnant. Women who smoke during pregnancy tend to give birth to babies with a low birth rate, which affects lung function and the increased risk of asthma for their child. When discussing food allergies, research suggests that peanut and milk allergies may increase asthma severity. Indoor chemicals, such as indoor cleaners and household cleaning products dealing with the furniture and different things in your home, can be an asthma trigger. Air pollution, such as fossil fuels and other chemicals that contribute to air pollution, may worsen a child's asthma symptoms. Another cause is infection. Although specific circumstances can occur, viral respiratory infections are unlikely to cause childhood asthma, but can play a pivotal role in the worsening of a child's existing asthma. Common respiratory infections that cause colds, such as the rhinovirus, may be associated with the development of asthma in some children, but is more likely to worsen existing asthma rather than be considered a direct cause. The RSV, or respiratory syncytial virus, is unlike most infections that affect children. This is a major viral cause of infant pneumonia and has been associated with the development of asthma. There are many risk factors to point out that are highly associated with asthma among children. The first is gender. It is important to report that in younger children, asthma develops twice as frequently in boys than it does in girls. After puberty, a gender switch occurs and asthma becomes more prevalent in girls than in boys. This switch is related to an increase of sex hormones. As Daniela previously mentioned, race and ethnicity is a common risk factor discussed while on the topic of childhood asthma. African American children have significantly higher rates of asthma than Caucasian children and Hispanic children. However, both African American and Hispanic minorities are more likely to have fatal asthma than Caucasian children. Ethnicity and genetics are less likely to play a role in these differences than socioeconomic differences among them. These differences can be attributed to factors such as less access to optimal healthcare and a greater likelihood of living in an urban area with more risk of environmental factors or environmental irritants that can cause the asthmatic response. Another risk factor is issues surrounding birth. A variety of pregnancy and perinatal factors have been associated with the risk for asthma. Babies with a low birth weight are at a higher risk of lung problems and the onset of asthma. Interesting enough, some studies have suggested that children born in the winter may have a greater risk of asthmatic allergies to cockroaches than children born at other times of the year. Complications of pregnancy, specifically involving the mother's uterus, have been associated with an increased risk of childhood asthma. Lastly, among other benefits to the child, breastfeeding for a baby's first 3 months of life exclusively may help reduce the risk of asthma. Although these factors are not well studied or proven, it is important to make note of these associations when discussing issues surrounding birth. Continuing the discussion of risk factors, the first factor mentioned is obesity in overweight children. There is a strong association between obesity and asthma. Children who are overweight with a body mass index or BMI greater than 25 also have more difficulty getting their asthma under control. Children who are suffering with obesity or being overweight can benefit from weight loss and physical activity. Weight loss helps to reduce airway obstruction and can improve lung function. Physical activity can help with the weight loss process as well. As fitness improves, asthmatic symptoms improve also. At least half of patients with asthma also have GERD, or gastroesophageal reflux disease. This is the cause of heartburn. GERD presents itself in older children and adolescents. It is not clear if one condition causes the other or whether both conditions are both due to common factors. Although GERD can be treated, the treatment of GERD specifically does not appear to improve asthma control. Lastly, aspirin-induced asthma is a less common condition in which asthma is worsened after taking aspirin or other non-steroidal anti-inflammatory drugs. Aspirin-induced asthma typically develops after a viral infection when aspirin is given to help ease pain and/or discomfort. Some research indicates that acetaminophen or Tylenol may also trigger or worsen asthma, particularly in children. Although this link is not yet proven, parents whose children have asthma should be alert for this possible effect. In terms of long-term outlook, asthma generally improves as children get older, although most school-aged children with persistent asthma will still experience symptoms throughout adolescence. Some children outgrow their asthma altogether by adulthood. In general, the more severe the childhood asthma, the greater the likelihood that it will persist throughout their life. Children adapt well to living with asthma, and even with severe asthma, they can function as well as healthy children in virtually all areas of life. There are ways that asthma can be controlled through individual efforts. It is important to reduce exposure to allergens in the home by changing cleaning products or chemicals, increasing cleanliness, and/or eliminating factors that are possible to do. Treating coexisting chronic conditions such as obesity can also help to improve asthma control. Now we'll pass it off to Funmi to discuss the individual level within the social ecological model.
My name is Fumi Balogun Victor, and I'm talking about the individual under the SEM. The individual comprises of like belief, knowledge, attitude, and skill. When talking about childhood asthma, a child should be educated on the medical diagnosis and why it is sometimes difficult to breathe. The child should be educated that the condition is not contagious and that it cannot be transferred to other people while playing. So the child should be made to know that he or she is free to play with other people. And the child should be educated on the triggers to avoid people that smoke, to avoid being around animals, and how to avoid those triggers. And it is also important for the child to know that he or she can live a normal life and that there is the need to take medication and use inhalers. Skill is also important in the management of childhood asthma. Caregivers should help the child to take control of the condition by coming up with a treatment plan and helping the child to understand the treatment plan. And then by teaching the child how to take the medication and to use inhalers, helping the child to connect with other kids that have the same medical condition, that is asthma, either in school or through doctors' offices or through the children's hospital. And then the child should be educated on the importance of having a healthy weight, because research has proven that people with obesity tend to have more severe cases of asthma. And then the child should be educated on when to ask for assistance or call for help. Maybe when the child feels cannot walk, cannot talk, should just be educated on ways to reach out to other people or to call out for help. Thank you.
Hello everyone, this is Michelle Flavian, and I'll be doing the community determinants of asthma among children. Asthma has increased drastically during the last decades of the 20th century, and it is considered a chronic disease. Homes that have cats, dogs, create bacterial dust that result in wheezing, which is one of the factors in children with asthma. Schools. Children with asthma are at risk for poor academic performance due to persistent symptoms of the disease, which causes them to be absent. School absences have been shown to be harmful academically. Approximately 14.4 million absences in asthmatic children happened in 2009. There are various triggers of asthma in schools, and they include mold growth due to accumulated moisture, dust from stuffed animals from home, dust from pets at home, secondhand smoke, and dust mites. School personnel and teachers' preparedness is key in schools, and they would include having an emergency action plan in the classrooms, in the nurse's office, reporting mold growth to principals and administrators, avoid the use of aerosols, which can affect the lungs, encourage a good communication between student and teachers in order to better assist the asthmatic student in time of need. Living close to a park or having greenery close by is a great asset for children with asthma, since it helps reduce asthma symptoms. In contrast, the farther a family lives from a park, the symptoms worsen even more. Living close to a park promotes physical exercise and lowers pollution, which as a result improve asthma symptoms, in contrast to living in the city, which worsens asthma symptoms due to high air pollution. The improvement of symptoms appears to be higher in children 6 years or older, since they are free to move around more compared to younger children.
Hello, my name is Kelly Mary, and I will be discussing the societal aspects of asthma. The societal aspects of asthma are broken down into 4 categories, which are poverty, stress, violence, and the environment. Let's start with poverty. Poverty relates to the socioeconomic status of populations and families. Non-white children residing in urban areas and children living in poverty have a significantly higher risk of asthma and higher disease morbidity than do white children. Research shows the association between growing up in conditions of childhood poverty and elevated exposure to a broad range of health-damaging conditions increases the child's risk of asthma. Poor children are exposed to higher level of family turmoil, violence, separation, instability, and chaotic household conditions. Also, compared to children who reside in high socioeconomic status households, poor children are more likely to have poor sanitation, they will consume more polluted air and water, and they live in more dangerous neighborhoods. Although the physical characteristics of neighborhood and housing environments, such as air pollution, dampness, dust, and the presence of pests, contribute to variations in the risk of asthma within populations, these factors alone do not fully account for the social distribution of childhood asthma. Evidence suggests that the social pattern of asthma reflects differently to exposures to pathogenic factors in both the physical and social environments. Now let's talk about stress. Stress enhances the susceptibility to air pollution in childhood asthma pathogenesis. Association with social economic status can cause acute and chronic stress. The degree of chronic stress is significantly influenced by the characteristics of communities in which we live in. An example of chronic stress is a child living in a substandard house where high crime and violence exposure occurs on a daily basis. This child will be constantly worrying about their family and its own well-being. Higher stress levels lead to poor health, which then can cause asthma. Violence is another part of societal aspects to asthma. Studies have shown that families with children with asthma who moved to apartments in better neighborhoods rated their child's asthma as less severe after the move, independent to other factors. In another study, 851 children and their caretakers demonstrated an association between higher levels of community violence and increased caretaker-reported asthma symptoms. Increased frequency of exposure to violence in the communities predicted a greater number of asthma symptoms per day among the children, even after controlling the socioeconomic factors and housing dilapidation. Finally, the environment is a huge part in childhood asthma. The lower class is more susceptible to breathing in higher rates of traffic air pollution and regular air pollution, such as ozone and ambient particulate matter, which it can exacerbate asthma symptoms. For example, the people of lower class may live in poor residential conditions, such as crowding, which may predispose residents to viral illnesses, and deteriorating housing stock, which can increase exposure to indoor allergens, which then causes asthma. Not just lower class communities are at risk, but all communities are at risk of rapid change in the prevalence of asthma as living conditions change. Factors that contribute to this risk of asthma may include changes in diet and physical activity, infectious disease, and microbial exposures, increased exposure to antibiotics and vaccines, allergen exposures, exposures to indoor irritants, the effects of industrial and motor vehicle pollution, and psychosocial stressors, including violence. So what can we do to help? We can make sure the poor and minority children receive the appropriate treatment for asthma. We can also make sure that there are policies and interventions that are made to focus on improving the quality of housing and neighborhood conditions for poor children and minority children in particular. We need to promote health care so that children can afford medications. More funding, collaboration, and innovative approaches are urgently needed. And finally, inaction is not an option.
Here are the following references we used for this assignment. Thank you so much for listening.